Looks like we've got a really nice group here tonight. Thank you everybody for attending this evening. Really appreciate it. For those of you that don't know me, my name is Bwodlinger. I'm the Director of Research and Clinical Projects at Exact Imaging. And my pleasure to present tonight, getting back to ExactVu Micro-Ultrasound Biopsy. I know that many of you have been away from prostate biopsy for some time now, or at least under reduced load. And the concept behind this webinar is to give you a bit of a leg up in getting reacquainted with the system so that you can jump back into your increased caseload now that things are starting to open up. Just some housekeeping tonight. So again, we'll ask that everyone keep their video off to avoid any bandwidth issues so that everyone can see the slides and videos that I'm going to present. If you have any questions or comments, or you want to participate in our case review, please feel free. The chat is open, and I have the window open here. I will be looking through the chat and responding to it as it comes up over the course of the next 20 or 30 minutes. Okay, moving right along then. First off, I just want to thank and recognize our newest groups. We had quite a good beginning to the year before we got slowed down by the pandemic. 12 new systems from the end of last year, including 6 in Europe with 3 new countries and 6 more in the United States. I'm very sorry that not all of you have had your systems installed and finished your training yet. We are certainly very eager to come down and make that happen as soon as travel restrictions are lifted. Hopefully this is a nice introduction for you before your official training. So the first section of tonight's presentation is a review of some selected micro-ultrasound cases. And this is something that we do very often at Exact Imaging. In fact, weekly, our applications team meets to go over interesting cases that have been sent in from the field. If in the course of your using the ExactVu system, you come across some interesting cases that you think we might want to see, please do feel free to let me know and send them in. They could get featured on some of our online practice cases. Before we go into these, because they're a little bit more bandwidth heavy with the videos, I am going to turn off my camera. There we go. Here's the first case. Bit of an easy one to start with. Please feel free to put in some guesses in the chat window. Let me know what you think. I'll play that again. One more time. So what would be the Primus score on a case like this? I've circled it here. If you guessed a Primus 1, you would be absolutely correct. This is a very standard Swiss cheese Primus 1 feature. You can see the prostatic ducts here, several of them clustered, more over here, and throughout the tissue. The rest of the tissue is very nice and bright, hyperechoic tissue. This is very reassuring and has a very low likelihood of significant cancer. Moving on to our next case. This one's a little bit harder. You can see the needle there. This cine loop was taken with our needle enhancement feature active, which I know some groups like. It makes sure the needle gets highlighted with this kind of grayish blue overlay so that it's more visible. Any thoughts on this this base sample? Okay, just one more time now. Feel free to send me the message privately if you don't want to guess in front of everybody. Good, all right. So this was a Primus 4, and turns out it was a Gleason 7 cancer due to the mottled appearance. Very good, yes. Dr. Ward has done a good job with this one. Thank you, Dr. Ward, for chiming in. A Gleason 7, you can see here, there's no discernible ducts, and the tissue has a very uneven echo texture. It's bright in places and dark in others. The granularity of it is off. This can be quite a difficult place to assess the prostate because of the anatomy near the base. You have the ejaculatory duct, you have the central zone, which kind of makes can make the peripheral zone very irregular. But in this case, this is a very clear Primus 4, Gleason 7, mottled or smudgy cancer. Here's another interesting case. You can see over here a residual needle tract from a previous sample. This sample is taken fairly close to it, again with the needle enhancement active. What do you think of this one? What sonographic features do you see here? Is this a place that you might target or a place that you would leave alone? Glad to see some more participation, everybody. Thank you very much. We have some really nice comments here. Intraductal patches, indeed. We definitely see intraductal patches over here. Yes. Some stippling with some brightness. I completely agree. Very nice. And interesting, Dr. Pavlovich, one of our experts and one of our longest users of the system, says that it would be a target. Dr. Pavlovich, I think you're probably talking about this area right over here. And this is a really interesting example. So I would agree that you have this very odd area without any ducts, surrounded by ductal areas. So I would say Primus 1 on both sides. With this area, you could call it a Primus 2. But because this area is well defined and impinges a little bit on the posterior rectal wall, many people would categorize this as a Primus 3 and try and target this area in the center, which I would completely support, even though overall this is a lower risk prostate. Let's move on to our next case, case number 4. I really love this case. This is a really interesting case, and it's one that newcomers to the system often have a little bit of trouble with because it's something that we don't talk about too often. I'll tell you ahead of time that a biopsy in this area was positive for clinically significant disease. So take a look and let me know if you can think about why. Dr. Pavlovich, again, jumping in to point out that we have a very nice bulge at the capsule here. Yes, quite right, Dr. Pavlovich. One more time so everyone can take a good look. And there's something else that's interesting here too. So first of all, there's this bulge on the posterior side. Interestingly, we also have something going on the anterior side of the peripheral zone up here. This is an area where we should see very nice definition between the transition zone or central zone and the peripheral zone. And we do see that for part of the length of the prostate, but not the whole prostate, particularly over here. You can see that the border between the peripheral zone and transition zone is entirely disrupted. It looks like there's been some disruption of the zonal anatomy of the prostate here, which is, of course, very suspicious for disease. And the tissue itself is quite heterogeneous. Yes, you absolutely might call it a mixed hypoechoic lesion or a mixed echo lesion here. And it comes down to the anatomy. So if you think about the medial aspect of the prostate as kind of the Nike swoosh, I hope nobody from Nike is on the line now, but you have the peripheral zone, the apical horn of the peripheral zone up here, and it comes down to a very nice point at the base of the prostate. And the definition, especially medially, between the peripheral zone and the transition and the central zone should be quite strong. Here's another example. Just giving it a second for it to come up. Here it is. Here's another example of the same phenomenon. You can actually see the ejaculatory duct coming off the seminal vesicle very strongly here. And then we lose it, particularly up near the apex of the prostate. The zonal anatomy is completely disrupted. And that's a very strong sign that something is going on inside the prostate. So moving on now to our fifth case. This is our last case today. This is a really interesting case. You'll notice we're in a larger preset right now. I want you to take a look through the whole image here and tell me what you see. Bit of a clue there at the end. Any thoughts on this case? Take a look through the whole prostate here. Yes, very nice. A couple of very good responses about these bright echoes in the apical horn. That's a good catch. Oh, and a discrete nodule in the TZ. Yes, very good. One more time through. Okay. Let's look again. So first of all, if you thought this was suspicious here in the medial apex, I completely agree. A Primus 3 bright echoes for sure. I wouldn't go as far as a Primus 4 starry sky because the background is still hyperechoic, but certainly this is something that we might want to target. However, if I play the video again, you'll see a needle coming in here, and indeed this was a transperineal biopsy of an anterior lesion. You can see the hypoechoic nodule up at the top. Really nice sample of that hypoechoic lesion in the anterior. And that was in fact a Gleason 7 4+3. So this is just to say that we can't assign a Primus score here. Primus was only validated in the peripheral zone. But there is increasing evidence now that micro-ultrasound and ExactVu are able to distinguish nodules in the transition and anterior zones of the prostate, particularly hypoechoic nodules like this. If we're looking carefully, we can see some irregularity in the anterior capsule. We can see that the boundaries of this hypoechoic area are not smooth. They're fairly irregular, particularly over here. Looks a little bit infiltrative, and this is something that we're starting to really look at very carefully, and in order to try and generate a new version of Primus that includes these anterior and transition zone lesions. Okay, moving on. Let me just clear the screen from some of these annotations. There we go. Well, so if we're getting back to biopsies now, once we've gone over our case review for learning how to look through these images, let's talk a little bit about the actual use of the system. Here's the ExactVu system that many of you have sitting in your clinics or ORs. And of course, this is a side-fire system. The ExactVu EV29L transducer is a side-fire transducer, meaning it images perpendicular to the handle. not an end fire, which images in line with the handle. And so the movements are a little bit different. We want to move in to image the base of the apex, or the base of the prostate, out to image the apex of the prostate, and roll around the handle to go from left to right. And once the probe is in, of course, we try to keep it aligned with the spine so that the patient is as comfortable as possible. And then we want to optimize our image. And the first thing we optimize is for prostate size. There's 3 different presets that you can use using this image preset button up here. And those are large, medium, and small. Large being our 5 centimeter depth, medium 4 centimeters, and small 3 centimeters. And it's always good, I always recommend that everyone starts so that they can visualize the entire prostate. If you've got a small prostate, then that might mean the small setting from the start. In a larger prostate, you might start in large mode, do some interrogation, do your volume measurement, and then come down into small when you're assessing the peripheral zone. It's important when you're trying to read primus in the peripheral zone to always go down to medium if you need to, but preferably small, so that you're getting the best possible resolution. Once you've adjusted the size of the image, you can start adjusting the brightness. The gain knob is here in the middle of the console. And this adjusts the overall brightness of the image. After you've adjusted overall brightness, you can correct the uniformity using the TGC sliders. And this is useful, for example, if the rectal wall is a very strong reflector. Often it's very bright, much brighter than the prostate tissue. And so, of course, you can do a bit of a J shape here and decrease the gain in the shallow part of the image so that you don't saturate with the highly reflective rectal wall. Some people also like to make it into a backwards C and to curve down in the upper part of the image to avoid some of the noise. If you're picking up a lot of extra noise, if it's too bright in the anterior part, and that's fine too. Finally, we have the dynamic range button over here beside image preset, and this controls contrast. So not as often used as the other settings, but particularly if you're looking in the anterior of the prostate and you need things to be a little bit more black and white so that you can pick out some of the harsher edges, for example, from the anterior capsule. A nice thing to do to just put that down by a few clicks and see if it helps. Finally, we don't talk a lot about biopsy technique in our training, but one thing that we really like to emphasize is sampling of the anterior horn. And that's because this is a really different technique than what you see with standard end-fire transducers. And it's been known for some time now that side-fire transducers do not do this well unless you know what you're looking for, unless you use a special technique to sample this part of the prostate. And it's an important part of the prostate. But 30% of prostate cancers are in this apical horn. So please make sure that you tilt the transducer by moving the handle away from the patient's legs. And that compresses the base part of the prostate and lines up that biopsy guide to a steeper angle so that you can capture the tissue from the apical horn with a single needle. Then rotate to maximize the size of the horn and pull out to align your guide to the horn so you can sample it. For those of you that have had feedback analyses done where you can receive certificates from us, this is one of our points that we always measure. We actually will measure the distance from the biopsy guide to the apex of the prostate just to make sure that you're getting a really nice sample there. Great. Any questions so far on the case reviews or on the biopsy technique that we've covered? Please feel free to put them in the chat and I can address them as we go. So the next thing I'd like to do tonight is go over some of our more recent clinical data. Many of you know that micro-ultrasound first came on the scene with a publication in Urologic Oncology in 2013. And since then, the data has been coming very, very quickly, particularly this past year. Things have gone very fast, and we had several very important publications in late 2019 and early this year as well. The first is a review article by Lawrence Klotz. So I'd like to really thank Dr. Klotz. This was really an excellent review. And he went through several of the recent studies and compared micro-ultrasound to MRI as an alternative to MRI for imaging prostate cancer and for doing prostate biopsy. And his conclusion was that micro-ultrasound represents an appealing approach to men at risk for prostate cancer and has the potential to solve many of the problems associated with an MRI-first approach. Following closely on from that was an article from Claros et al. From the IMM group in Paris. And this was a very interesting study documenting their switch from Artemis-based fusion biopsy to ExactVu cognitive fusion biopsy. And what they found was, despite the fact the random sample detection rate remained essentially the same, the targeted sample detection rate increased dramatically in the ExactVu cognitive fusion group compared to the robotic fusion group. And this is really interesting. They had a lot more experience with Artemis than they did with ExactVu. This documents approximately the last 200 cases of Artemis biopsy and the first just under 50 cases of ExactVu biopsy. So I think it says something about the learning curve as well and the difficulty of the procedure, as well as the accuracy for identifying, in this case, MRI-directed targets. Next is a paper from Luger et al., Dr. Leudl's group in Linz, Austria, which was published in the Annals of Urology and Nephrology. And this was, I think, the largest series to date. It includes almost 6,000 biopsy samples that were very rigorously labeled with the Primus score. And the overall area under the curve for Primus to predict the presence of grade group 1 or higher cancer was 0.76, which is quite strong. More interesting, there was strong uniformity across the prostate regions. This was quite unexpected. So we looked at the base, mid, and apex, and also the lateral to medial and right to left. And there was really no significant change in the accuracy in each of those different sections. In fact, there were even a small number of anterior samples where they gave a Likert score, not Primus per se, but they felt confident giving a risk score in some anterior samples. And the area under the curve of that was actually 0.8. It was quite strong, which really gives us hope that we'll be able to come up with some addition to Primus to cover anterior zone and transition zone quite soon. As you can see, the risk stratification was very good. The positive rates for Primus 1 cases was about 4%, whereas for Primus 5 cases, the significant cancer rate was 71%. Just pausing now for a question from Dr. Pavlovich about perineal biopsy. Yes, we do have quite a number of groups now using the system for transperineal biopsy. In fact, we have a new disposable clip-in that makes the transperineal procedure a little bit easier, I think. It is certainly much easier to do the anterior samples and does get quite nice samples of the apical horn as well. So if anybody's interested in finding out more about using the system for transperineal biopsy, happy to discuss it later on in the presentation or via email or a phone call later on. Next up, we actually had a nice meta-analysis by a group that are not yet users of the ExactVu system, Zhang et al. In Frontiers of Oncology. And they reviewed all of the current literature, 7 studies at the time, on micro-ultrasound, not comparing it to MRI per se, but looking at diagnostic value. And they found a sensitivity of 91%, slightly lower specificity of 49%, which is, I think, fairly reasonable for a biopsy type test, with a diagnostic odds ratio of 10 and an area under the curve actually slightly higher than shown in the Luger paper of 0.82. Really, really nice statistical work in this paper. And then finally, just published this week, a study by François Cornu and colleagues in European Radiology. Dr. Cornu used micro-ultrasound as a second look after biparametric MRI in 118 patients. So that means all of these patients were positive on biparametric MRI, coming in for a biopsy, and the biopsy procedure was completed using the ExactVu Micro-Ultrasound system with either cognitive biopsy or FusionVu, the FusionVu feature, depending on the lesion. And very surprisingly, no significant cancers were found in MRI lesions when the micro-ultrasound was negative. So, for example, if there was a PIRADS 4 lesion, and when Dr. Cornu imaged it on micro-ultrasound, he said that the tissue looked normal. There were 13 of those lesions, and none of those lesions came back as significant cancer. On the other side, most of the lesions were actually visible with both modalities, and this is a retrospective visualization, of course, because we knew where the MRI lesion was. This was not blinded, but in 114 lesions where MRI and micro-ultrasound were both suspicious, 70 of them, 61%, ended up being significant cancer. On the other side, there were many lesions which were visualized on micro-ultrasound, but not on MRI. So of 17 of those lesions, about 24% of them were positive. 4 of the 17 were positive for significant cancer. So that suggests that micro-ultrasound may be very interesting, particularly in cases where it's important to learn the full extent of the disease, including satellite lesions, both ipsilateral and contralateral. We also have 2 papers in press at the moment. Socorros et al. From Madrid in Journal of Urology with the Madrid protocol, a new transperineal protocol which combines micro-ultrasound and MRI-guided biopsy. Quite nice results there from almost a mapping style of biopsy. And the Shao et al. IEEE Transactions in Medical Imaging paper, which documented a new AI system, machine learning system, for automated cancer detection in micro-ultrasound images with quite high accuracy, I think much higher than has been demonstrated previously either in micro-ultrasound or in conventional ultrasound images. Now, of course, this was just a short presentation tonight. I imagine many of you are looking for more. We have all of our e-learning material now, due to the COVID pandemic, available for free online open access. So please feel free to go to www.exactimaging.com/elearn. There you can find all of our e-learning modules that many of you completed prior to your training, as well as a series of practice cases in this tab over here, which, much like tonight's case review, contains some interesting cases that we have found and discussed as a group, as well as training videos with things like probe preparation and cleaning and disinfection. Thank you very much, everybody, for your attention tonight. While we do have a significant stockpile of disposables now at Exact Imaging, anticipating your orders now that things are ramping up, I do want to ask you to please remember to have sufficient disposables on hand and order early, as we are anticipating delays in shipping and a higher volume of cases in the coming days. So please do take that into account when you're planning the next few months. I'd also like to thank Andrew Lewis, our Senior Clinical Application Specialist in Europe, who helped prepare the cases for tonight. And with that, I will leave this on for the next few minutes to take questions. Thank you very much.